Hello people, this is Dr. Muskaan this side, and today I'm going to discuss a very beautiful case with you. Here is 77-year-old male who has came to ER with chief complaint of abdominal pain and vomiting since 2 days. On arrival, ABCS was done, airway was patent, there were no signs of airway obstruction. To your acknowledgement, what are the signs of airway obstruction? They are dyspnea, dysphagia, choking. Patient is not able to take breath while sleeping or lying down on the bed, like there is something called orthopnea. He's holding his neck and feeling like there is some hair hunger. So these are the signs of airway obstructions which were absent in the patient. That means airway was patent. I told you that because next point I'm going to tell you that will be about breathing assessment, and most of the people get confused what is the difference between airway and breathing. So when airway is compromised, generally we do intubation, but when breathing is compromised, we do something that is something like correcting the oxygen saturation of the patient. Like patient can be on NRBM or on oxygen through NIV or any other thing. So yeah, on breathing assessment, respiratory rate was 18 per minute, SpO2 was 93% on room air. On circulation assessment, pulse rate was normal, BP was 160/80, that means patient was hypertensive. Sensorium was alert, that means GCS was 15/15, E4, V5, M6, that means he was opening eyes spontaneously, verbal response was oriented, and motor responses he was obeying command. So from ABCS we have came to know that patient was hypertensive, rest all things were normal. HOPI, patient was apparently asymptomatic when he came with the complaint with pain in abdomen which was acute on onset, progressive in nature, associated with loss of weight, loss of appetite, obstipation. He also complains of vomiting which contains water along with food particles. It was twice done. Associated with cough with whitish sputum. Cough increases on exposure to cold, that means seasonal variation was present. Past history, he is known case of type 2 diabetes mellitus since 2 to 3 years. He is not on any medications. There is no history of TB contact, hypertension, thyroid disorder, epilepsy or any other chronic illness. Negative history, there is negative history of diurnal variation, dust allergy, steroid abuse, MDI, DPI use. Personal history, so what is MDI and DPI? MDI is meter dose inhaler and DPI is drug powder inhaler. Now what is the personal history of the patient? It was history of smoking since 45 years, but he has left his smoking past 1.5 years back. There's history of alcohol since 30 years, but he has left alcohol 8 years back. There's no history of tobacco chewing. General examination, decubitus, patient was lying comfortably on bed. He was oriented to time, place and person. Vitals, BP was 180/82, pulse rate was 108 per minute, respiratory rate was 30 per minute, SpO2 was 93% on room air. Temperature was 100 degree Fahrenheit. Out of parallel icterus, clubbing, cyanosis, edema and lymphadenopathy. Parallel was present, that was moderate, rest all were negative. So till now, what are the positive findings? Positive findings are hypertension, tachycardia, tachypnea, fever and anemia. That means parallel was present. So investigation picture of the patient. Hemoglobin was 8.8 gram per dl, that shows anemia. TLC was 21,000, that shows leukocytosis. KFT picture shows hypouricemia. LFT picture shows hypoalbuminemia. On AFB stain there was no acid fast bacilli which was found. On biochemistry analysis of ascitic fluid, there was total protein of 3.6 mg per dl, that was exudate. CT scan of whole abdomen shows ascites, bilateral pleural effusion with subsegmental collapse and mild splenomegaly. Typhoid.IgM was positive, dengue malaria was negative. ECG picture shows M pattern in V1 and W pattern in V6, which shows right bundle branch block. So friends, what are the DDs of right bundle branch block? Okay, we came to know that M pattern and W pattern in V1 and V6 respectively, it is right bundle branch block. But what we will think further? The DDs for right bundle branch block are myocarditis, myocardial infarction, cardiomyopathy, atrial septal defect, cor pulmonale, and pulmonary embolism. So further PT INR picture shows raised prothrombin time. INR was normal. HBS AG, HCV, HIAV 1 and 2 were all non-reactive. USG picture shows altered hepatic echo texture, GB sludge with edematous and thickened gallbladder wall, mild splenomegaly, right renal concretions, prominent ileocecal junction with adjacent fat standing, left renal simple cortical cyst, moderate to gross chronic ascites, and mild bilateral pleural effusion were all these things were present. So serum amylase and serum lipase levels, what about them? Serum amylase level was normal and serum lipase level was more than 3 times of its normal value. And what we see from amylase and lipase level, if it is 3 times of its normal value, we think on the line of pancreatitis, but in this case lipase are more than 3 times but amylase are normal. So right now sepsis में तो है patient because 4 points for SIR is positive and infection is also present like raised TLC count. ABC picture shows respiratory alkalosis, chest X-ray shows consolidation in left lung on the lower lobe which is homogeneous. There are marked bronchovascular markings, blunting of CP angles is there which shows pleural effusion too. So what are RDDs? First is TB. Why? Because there is fever, loss of weight, loss of appetite. Your AG ratio is reversed, that is 0.6, which is highly suggestive of chronic infections such as TB. Second DD is your subacute intestinal obstruction. Why that? Because fever, abdominal pain, vomiting, and obstipation is present in the patient. Third of all, it can be portal hypertension, but platelet levels are normal. Okay, we see that ascites is present, pleural effusion is present, mild splenomegaly is present. For saying portal hypertension, we should have 2 positive findings. One is the splenomegaly and another is the thrombocytopenia. But there are normal platelet levels, so we can rule out portal hypertension, but we can also wait for endoscopy reports. So till now, okay, on the next day we did ADA test, which is adenosine deaminase test, which tells us that if there is any tubercular bacteria present in the fluid which is in the peritoneal cavity. So it was normal. No, it was 25.3 micro per liter. If it is more than 40, then it comes out to be abnormal. So there is no tubercular bacteria in the peritoneal fluid. Further, there was one test that was serum acetic albumin gradient SAG Boltzmann, which was 1.82 gram per dl, that is more than 1.1, which also is related with portal hypertension. And CECT scan whole abdomen reports on the next day were showing subsegmental collapse, and there were aphthous ulcers which was present in endoscopy report, which can take us towards Crohn's disease also, because the points which are favoring the diagnosis of Crohn's disease is of pain of abdomen, fever, weight loss. CCT scan shows subsegmental collapse, endoscopy shows aphthous ulcers, and one of the complication of Crohn's disease is your intestinal obstruction. The signs of intestinal obstructions were also present in the patient, such as fever, abdominal pain, vomiting, and obstipation. So take home message from this video to you is, when we don't understand what is our DD out of so many things like TB, SAIO, portal hypertension, or Crohn's disease, just make your diagnosis towards TB and make that patient on ATT. That's all. Thank you for watching this video. I hope you get to know some good points. Dr. Muskaan signing off now.